All right, good evening. My name is Rich Pizzillo. I'm the Executive Director of the New England Hemophilia Association, and welcome to our 5th Annual Consumer Medical Symposium. This important event began 5 years ago and was based upon community feedback. Each year, this event is hosted in one of the New England states and is always held in March, which is Bleeding Disorder Awareness Month. There are 3 pillars to this event: understanding current and potential treatments, understanding the insurance barriers that are put into place, and understanding the psychosocial impact of change with all of this. This event, as I mentioned, began in 2016 and has been hosted in the following cities: Portsmouth, New Hampshire, Portland, Maine, Southbridge, Massachusetts. Last year was virtual, this year it's virtual, and next year we are really hopeful to be in Connecticut, where this was supposed to be last year. Still have the contract at the hotel, so we're coming for you, Connecticut. Tonight is part 1 of this series. This series is, again, throughout the month of March, and we'll get a little bit more into what this series looks like over next week on Saturday, March 20th, and then the following week. But you will be hearing lots of different pieces of it. And for those, we'll get into this later too, that are registering for the Saturday, March 20th event, you also get a NEHA very new fanny pack, because the 90s and the 2000s are coming back. So you always need your fanny pack, because this conference is helping you put your tools to be a better advocate and patient into that tool belt, aka fanny pack. You also will be receiving a $25 Dunkin' Donuts gift card to help cover breakfast, since food is often something that brings our community, our family together at events, to help cover the cost of that during the event itself. We are thrilled tonight to welcome back someone who actually helped NEHA start this event, Dr. Stacy Croteau, who is our keynote speaker, who is a pediatric hematology and clinical researcher at the Dana-Farber Boston Children's Cancer and Blood Disorder Center. I would love to hear you say that really fast and see if it's a tongue twister there. Dr. Croteau joined the Boston Hemophilia Center in 2014 and became the medical director in 2019. Her primary areas of academic interest are early drug development, advancing an approach for rationally designed personalized prophylaxis regimens in hemophilia, and quality improvements efforts targeting patient transition from pediatric to adult. She serves and chairs on many national and local committees, and as I mentioned, also helped NEHA form this very event back in 2016. So before I get started and turn it over to Dr. Croteau, I just want to go over a couple of points. You all are pros at Zoom, but you can turn your camera on, you could turn your camera off, you can listen on your phone. This will approximately be about 1 hour. It may go a little bit longer because there's a lot to cover tonight. And we, of course, welcome your participation. A lot of you submitted questions ahead of time, so all those questions that came in over Zoom have been sent to Dr. Croteau. But if you have other questions, you won't interrupt the presentation by just putting them in the chat, and we'll be sure to ask those at the end of the presentation. If you have tech issues, don't worry, it happens to all of us. I may freeze here, and if I do, Sarah will take over. We're going to do a couple of polling. So if you've never done this before, it's a great way. So grab your phone, and I'm going to share my screen. All right, so the first polling question is, what do you like most about the spring season? This could be anything. And if you've never done this before, all you have to do is text 781-412-7971. And there's no right or wrong answer with this. So it's 781-412-7971. So hope, flower, sun. We got Sullivan's reopens, nice. Longer days, 60 to 65 degrees weather. Red Sox, yep. So anything that comes up larger are things that are said multiple times. So first day with the windows open, I don't know about you, but I definitely had the windows open yesterday and today, and tomorrow definitely looks like open all the windows there. Golf, absolutely. Flowers, leaves, etc. All right, so let's go to this question now. What is one habit, good or bad, that you formed over the past year? Don't worry, we cannot track you, so we're not going to call you out on these habits here. But what's one habit, good or bad, that you have formed over the last year due to the pandemic. So volunteering, daily walks, yoga. Let's see, bad sleeping late, drinking too much, working out intensely. Kudos to whoever put that. Let's see, drinking too much wine. Lots of reading, reading for pleasure. Yoga is definitely a theme here. We have not done a yoga virtual class yet, but we may have to start our fitness classes back up and do yoga. Stress eating, definitely have been there. Peloton, nice. Fitness, great Instagram skills. Wishing the pandemic away. Absolutely awesome. All right, so the next question is, how are you connected with the bleeding disorder community? So text 1 if you have a bleeding disorder, text 2 if you're a caregiver, text 3 if you're a spouse or partner, text 4 if you're a sibling, text 5 if you're a healthcare provider, text 6 for other. So these are all of the other categories. So we'll give this a second here just so we can see who is on. So it looks like about half have a bleeding disorder, about 30% are caregivers, 10% are partners or spouses, 3% are siblings, 6% are healthcare providers, and 8% is others. So the majority definitely have a bleeding disorder on here. Great. All right, I'm going to go to the next question. What comes to mind when you hear the term emerging therapy? Again, there's no right or wrong for this, but what comes to mind when you hear the term emerging therapy? This could be anything here. Innovation, hope, new technologies, not finished yet, new treatments, novel, in clinical trials, absolutely. Products that are not available yet, innovation, improvement, NFT and GT. Great. Fantastic. Cell therapy, hope. All right, let's go on to the final question here. What are you hoping to take away from this presentation? This could be anything here. Great, we have hope again, knowledge, a better understanding, new knowledge, a lot of knowledge here, which is great because you came to the right place. New treatments on the horizon for VWD, a high level view of what's coming next, knowledge again, cell therapy, what is it? Okay, fantastic. So I'm going to stop sharing my screen there. Before I turn it over to Dr. Croteau, I'm just going to share my screen one more time to just go through a couple of more housekeeping items here. This is the agenda for the upcoming. We will go more into this, but next week we have a great panel, interactive live sessions, scavenger hunt, exhibit hall, which we'll get into a little bit later. I want to thank our Consumer Medical Symposium Committee, Mark Borlich, Janet Brewer, Diane Bruno, Heather Hoysted, Margaret Hudlin, Rachel Katzman, Pat Mancini, Carolyn Miazga, Mike Rudishan, and Mark Saturka. Many of you have been involved since the very beginning. Thank you so much for your efforts for putting this together. I want to thank you for being on this tonight. And of course, I just want to thank our sponsors as well. Presenting sponsors, Bayer, CSL Behring, Genentech, Novo Nordisk, Octapharma, Sigalon Therapeutics, Spark Therapeutics, Takeda, and Unicure, followed by our champion sponsors, BioMarin, Sanofi Genzyme, and Pfizer, and our advocate sponsors, Accredo, Biomatrix, CVS Health, Drugco, HFA, Paragon Healthcare, and Superior Biologics. Thank you all for continuing to support our mission throughout this pandemic. So without further ado, I'm going to turn it over to our keynote presenter, who I'm going to spotlight. Dr. Croteau, you can share your screen now, please.
Excellent. Thank you. Perfect. Hopefully everyone can see that. Thank you so much for that kind introduction. Thank you for inviting me back. It's hard to believe it's already been 5 years since our very first medical update. And I'm excited to share that there have been a lot of ongoing updates that hopefully we'll be able to get to today. So a few quick disclosures just for active work that I've been doing either in research or consulting, either active or over the past year. So to put it in perspective, we have about 45 minutes or so for both presentation and questions. And so the goal really is to update all of you on some of the new potential treatments that are under study. But I think as someone requested kind of that 10,000 foot view, this is very much sort of in line with my goals for this evening to help sort of whet your interest, whet your appetite with some of the types of therapies that are coming, some of the data around the new therapies. But I don't have time to talk about every investigational therapy. There isn't enough time. And then even within many of the therapies I speak about, I don't have time to kind of go into great depth into all of their data. I do try to at least highlight by name, and we'll go through quickly on some of the slides so that you can appreciate the breadth of the clinical research programs that are currently underway. And each of the manufacturers, each of the teams, each of the sponsors, I think are doing a really great job and have some fantastic data to share. And it's been really exciting, even over the last year with virtual meetings, the virtual congresses and the amount of data and new information coming out about these therapies has just really been extraordinary. So it's certainly an area of a lot of innovation and a lot of fast moving and new data. So good that we continue to have these annual and also with the fall and spring meetings, biannual updates, because there's a lot of information coming. The other important thing is that each of the therapies that we're discussing tonight are really investigational. They're under study. So nothing that I'm talking about has been FDA approved for any indication yet. To put it in context, we've had some really positive changes, as many of you know and have lived through, in bleeding disorder outcomes with the therapies that are already available. And this is just a brief timeline to highlight how relatively recently we have tried to institute ideas and had therapies to institute ideas like prophylaxis. And we've seen with each successive generation increase willingness to be on prophylaxis, increase access to the therapies for prophylaxis. And as we've increased that, we've seen a decrease in physical activity limitation, improvement in quality of life. And you'll even see, the last cohort listed here is an aging cohort, right? The early 80s to 90s. And, as we add arrows for the newer generations, that proportion on prophylaxis continues to go up. In a lot of respects, the limitations overall continue to go down. And that's all very positive. So if we have therapies to replace our missing clotting factors, why do we need innovation? We still have a lot, I think, and this group appreciates this very well, but as we're talking with various companies, as we're talking with various payers, as we're talking with legislatures, understanding why these therapies and why this innovation continues to be important is really critical. And I think burden of treatment is one of those really critical elements. And so in some ways, it makes me happy to hear, oh, we have great therapies for hemophilia, for the other bleeding disorders. Children are living normal lives. And while it's absolutely true that we're doing a much better job as a group helping to keep kids in school, reducing the amount of time they're in the emergency room, that they're having active bleeds, that they're at home, that they're playing sports. As you guys well know, the behind the scenes of that sort of quote unquote normal life is still a lot of work, a lot of burden of every other day, 3 times a week, multiple a week infusions. Now, of course, some have some options of newer therapy. There are subcutaneous injections, which does decrease the burden to some extent, but there's still a lot of thinking about hemophilia, von Willebrand disease, other bleeding disorders, and a lot that goes on to the current treatments. With many of the current treatments, we have rapid change in factor levels. As you infuse your von Willebrand clotting factor, as you infuse your factor 8, your factor 9, your levels go up to the normal range, but then they quickly begin to fall. So over a matter of hours or days, you're back to a mild deficiency, moderate deficiency, potentially back to severe disease. And it can be hard in many cases to match up infusions with sports events, with various physical activities that we want to do, with injury and trying to prevent bleeds. And so that rapid fluctuation is another burden. We have infusion challenges, though many, even at very young ages, have become impressively skilled at intravenous infusion. That is a skill and that is a challenge. When you have an active bleed in your elbow, it can be very challenging in that sense to infuse yourself. If you happen to have small veins, no matter what age you are, it can be very difficult to infuse yourself. In many cases, we need to add additional access, central lines, portacaths, broviacs, in order to be able to achieve those infusions of necessary therapy. And as many are aware, those come with their own sets of complications. And to be honest, we also just have room for further improvement in outcomes. We've seen dramatic improvement in joint health because of prophylaxis, particularly in hemophilia. But when we look at joint outcome studies, especially this longer term outcome study from starting young children on prophylaxis, those who started prophylaxis early, around 2 years of age or so, had much better joints when they went back and looked over a subsequent 10 and 18 years. But there was still changes that they could see on MRI. And those that had delayed prophylaxis, not starting until 5 or 6 or later, had marked changes in their joints even from very early on. So prophylaxis certainly improves a lot of outcomes, but we still have a better job that we could do with more consistent factor levels, with less burden of therapy. So there's a lot of room for improvement and innovation. As we think about these new therapies, the way I've tried to present many of them, and the way I would encourage you to try to break them down in your mind, is by thinking about a series of questions. So one of the questions we're going to try to answer as we go through some different sections is, how does this new therapy work? Like, what is the mechanism of action? How is this supposed to work in my body? How is this medicine, how is this therapy different from the therapies that are already available? Where is this product in development in the clinical trial process? What have we learned so far about the effectiveness of this therapy? What have we learned so far about the safety of this therapy? And is it possible for me to access this therapy right now? So I mentioned that we have a lot going on in this space, a lot of innovation, a lot of new therapies. And so it can be a bit overwhelming, especially as you start to hear about different sort of alphanumeric codes that are used for different study drugs, some of the big, long, and complicated names that early on get assigned to these therapies, especially before the branding, the brand names that often come with these drugs that often are a bit clever and roll off the tongue a little bit easier. When they're still in the investigational mode, they can be quite challenging. So I try to break them down and think of them in different buckets. And so I presented these here in some colored squares. So some of the new therapies are factor concentrates. So we'll talk about a few factor concentrates that are different from what's already available, really new and innovative approaches. We have gene therapy, and in the hemophilia space, we're going to focus in particular on in vivo gene therapy. So this is gene therapy that all just takes place right in the body. There are cell therapies, and this is actually a mix of both gene therapy and some other approaches that use cell therapy to help treat bleeding disorders. And so we'll talk about some of those types. And then we also have these new classifications. So all of those at the top essentially help us replace the missing clotting factor, whatever it may be, von Willebrand factor, factor 8, factor 9, rare factor of choice. And then we have the other two categories that are really just different approaches to changing the way we make a blood clot, changing coagulation. And so we have these two new terms, substitution therapies and rebalancing therapies. And together, this is often the two groups that get referred to as non-factor treatment or non-factor replacement therapies. They try to change how well we make blood clots. Some of them may act similar to factors, but they're not truly kind of just replacing the missing protein. So I think of these as alternative approaches to thrombin or clot production. So believe it or not, here is a big list of new factor concentrates. So while we have kind of a multitude of factor 8s, factor 9s, a bit more limited in the von Willebrand space, and for many of the other factors, 7 is a bit growing, 10, we might only have one option in terms of a specific factor concentrate. Here are more. So there is at least 2 new factor concentrates for factor 8 that are being investigated. We'll talk a little bit more specifically about the one in orange, BIV001. There is another product called OCTA-101, which is being investigated as a subcutaneous administration of factor 8 to potentially try a new mechanism of administration. There is a new approach to factor 9, DALK-A, that you can see there, which also is a subcutaneous approach to factor 9 administration. So you can sort of see a theme in terms of we understand that intravenous injections are challenging. What are the opportunities for different modes of administering these types of factors? Are they safe? Are they effective? How do we think about the dosing and the time to effect when we inject something under the skin, where it takes more time to absorb than when we are able to infuse it directly into a vein? So those are being explored. There's also additional exploration going into factor 7 concentrates. So Mars AA, you see highlighted in orange here, we'll jump into in a bit more depth as well. So when we think about the first factor concentrate, as promised, alphanumeric code, so BIV001 is a factor 8 concentrate. How does this new therapy work? Like other factor concentrates, it is a concentrate of factor 8, is a recombinant concentrate, and the goal is to replace the missing factor 8. How is it different from therapies that are already available? Well, this one has been modified to last longer in the blood and modified in different ways than currently available factor products. So what you can see with this slightly complicated picture here is this is what happens in the body. So native factor 8 and von Willebrand. Von Willebrand, of course, is a protein. One of its jobs is to protect and shepherd around factor 8. So the von Willebrand is highlighted here in sort of this red maroon color, and the different components that make up the factor 8 molecule are in a turquoise and purple color. This newer factor 8 concentrate tries to mimic or tries to add some of the important stabilizing components of von Willebrand factor. So you see again in the turquoise and purple here are factor 8. There's this FC area added here, and you might recognize the combination of factor 8 and FC. That is recombinant 8-FC, which is an available factor concentrate. But this takes that molecule kind of another step and adds that stabilizing factor of von Willebrand factor component of D prime D3. It adds some other sort of protective X10 sequences as well to try to protect it and slow down degradation so that it can live longer in the blood and help us make good blood clots for longer. Where is this product in development? So this product actually has multiple trials that are ongoing right now. It is currently in the later stages, the phase 3 trials for severe hemophilia A. But they're also starting to explore the use of this coagulation product in phase 1 trials. So these are the first stages, early stage trials in von Willebrand disease for type 3 and also for 2N. So as many may know, von Willebrand disease is one of the more common bleeding disorders. Most individuals have type 1 von Willebrand disease, where their von Willebrand factors are lower than normal. Type 3 is the most severe form of von Willebrand disease, where individuals essentially make no von Willebrand factor at all. And when you have no von Willebrand factor, since protecting factor 8 is one of the key jobs of von Willebrand factor, those individuals also end up having undetectable or very low levels of factor 8 and suffer from both bleeding symptoms of von Willebrand disease as well as from those of factor 8 deficiency of hemophilia A. Type 2N von Willebrand is the type of von Willebrand where there's a specific mutation in von Willebrand factor that prevents it from binding normally to factor VIII. So for these individuals, again, different from the type 1 individuals, more like the type 3 individuals, they have von Willebrand disease, but they also suffer from very low levels of factor VIII. So again, their bleeding symptoms are often more similar to some of those with more severe factor VIII deficiency. So since factor VIII is a big component of the bleeding in both of those specific von Willebrand disease disorders, makes sense why they would try something like this product. What have we learned so far about the effectiveness? So the data that we have so far really is around severe hemophilia A. These phase 1 trials in the von Willebrand disease population are just getting started. But what we've learned so far from adult severe hemophilia A participants is that this new investigational factor VIII concentrate has a pretty long half-life, right around 40 hours. To put it in context, the half-life of our standard factor VIII concentrates right now is around 10 to 12 hours, the extended half-life around 14 to 16 hours. So this is substantially longer. And if you look at a graph of how this is different, what you can see here, probably looking on this y-axis, the percent of factor VIII activity, and you can see the days after injection along the x-axis. This light line is the change in factor activity after a standard dose. And so you can see by day 3 for many people falling less than 1%. But in comparison, for these individuals using this other product, by day 5, still in the high teens, 15 to 17%, and at 5% by day 7. So actually able, with weekly infusions at even a very standard dose of 25 units per kilogram, able to keep factor levels much higher. What have we learned so far about its safety? Individuals who have participated in the trials of this so far have been predominantly adults, though the age is marching down, and we do now have pediatric trials that are underway. So most of the individuals that have been studied with this have had a lot of previous exposure to factor VIII. So perhaps not surprisingly, but reassuringly, no one has developed inhibitors to factor VIII. No one with prior inhibitors has been part of those clinical trials, and as I said, had been previously treated. And then no one has been reported to have any significant hypersensitivity or anaphylactic allergic type reactions to this. Is it possible to access this therapy right now? So as I mentioned, there are multiple clinical trials recruiting in the adult population, in the pediatric population for severe hemophilia A, and also just getting started in early phase trials for some types of von Willebrand disease. So if you fit into those categories and this seems potentially interesting to you, I would encourage you to go to clinicaltrials.gov to learn more, both about this product, but it also will provide a list of sites where you might be able to contact the principal investigator to learn more or potentially participate if you're interested. The other factor concentrate that we'll just mention is this Mars AA, which is a factor VII activated concentrate. How does this therapy work? So this therapy, as is true for many of the factor VII concentrates, isn't always first studied for factor VII deficiency, as one would think, but in fact is first investigated for hemophilia with inhibitors as a bypassing agent. So certainly this medication works by increasing one's factor VII levels. So in the context of hemophilia with inhibitors, what this equates to is really driving thrombin generation, driving clot formation through the factor VII tissue factor pathway. How is it different from therapies already available? Mars AA is being investigated for subcutaneous administration. So while there are recombinant factor VIIa molecules available, those available are intravenous factors, where this is being investigated ideally for subcutaneous administration. And this molecule has been additionally modified compared to those that are commercially available to have a prolonged half-life, and also has some modifications to further increase its procoagulant, its clotability, essentially. So here's a cute picture of factor 7, and you can see there's a few areas of key modification within the protein, which is intended, as I mentioned, to extend the half-life and also to change its procoagulantness, how well it effectively kind of activates some of the other coagulation factors. Where is this product in clinical development? So it is in phase 3 trials, so later development trials for severe hemophilia A and B with inhibitors. It's also now in early trials, so phase 1 and 2 trials for factor 7 deficiency, and also for Klansman's thrombocythemia, which is a platelet function disorder. So as is true, and you've heard me say in the past, and you'll continue to hear me say, a lot of the molecules first get tested in hemophilia A and B, or hemophilia A and B with inhibitors, in part due to unmet needs and in part due to the more prevalent, the higher number of patients with those disorders. And then once there is safety, efficacy, and things seem to be moving forward in those disorders, then companies, sponsors, manufacturers look at, well, what other populations may also benefit, and then start kind of all over again from the earlier studies, phase 1, phase 2, to look at it in other bleeding disorder populations. And so that's what we see going on here. And what have we learned so far about its effectiveness? So in this particular image, what you're seeing is each of these numbers represents a different participant in the clinical trial. They received subcutaneously administered MARS AA. And what you see in the red are the bleeding rates before they started to receive MARS AA, in this case for prophylaxis. And then the green bars represent bleeding events that were recorded after they started this medication for prophylaxis. So what you can see for essentially all patients is that using this prophylactically dramatically reduced the rate of bleeding that they were having. It didn't completely eliminate bleeding for all patients, but really reduced bleeding rates. And what they're looking to do, especially in some of the more recent clinical trials, is not only look at this medication prophylactically or as a preventative treatment, but even in a subcutaneous administration to look at it as a bleed treatment. So for example, if you were on a prophylaxis regimen where you were already doing subcutaneous treatments, and for example, you didn't have IV intravenous infusion skills yourself, it might be really helpful to have a subcutaneous option to treat your bleeds in the same way that you have a subcutaneous option for doing your prophylaxis. And so this is what's being studied, and this is what they hope to achieve. What have we learned so far about MARS AA safety? They have not yet reported any anti-drug antibodies, significant adverse events, or thrombotic events, so abnormal clotting events. As we can see with many different subcutaneously administered medication, there have been reports, relatively infrequent reports, of mild or moderate injection site reactions. And those can run the gamut from some pain, some redness, some swelling, some bleeding, some bruising. Is it possible to access this therapy right now? So again, as I highlighted a slide or so ago, they are recruiting for multiple clinical trials for multiple indications. And so if you potentially meet any of those indications and are interested, again, definitely check this out at clinicaltrials.gov. It'll help you look at a list of sites that are participating. And in addition to talking with your own home hemophilia treatment center docs, it gives you access to sites and principal investigators who may know a bit more about this medication in particular to help you learn more and make a decision about potentially participating in a clinical trial. So let's move on to in vivo gene therapy. So in vivo is gene therapy that happens just within the body. And this is basically the category that we think of with AAV-mediated gene transfer. So how does this therapy work? So AAV is adeno-associated virus. It's a virus that is very prevalent in our respective environments across the globe, but fortunately does not cause active disease in humans. And so what we've done in this case is we've taken the AAV virus, which can infect humans, can get into our body and has predilection, likes to go to different types of tissues, and sort of harnessed it, since it doesn't cause infection, harnessed its ability to get into the human body and to go to different tissues. And rather than bring in viral genes and viral information, instead to bring in information about missing clotting factors. And so what you can see here is a revision of kind of the different components that would make up an AAV virus. And instead what we put in is what we call a transgene. And this could be a factor 8, could be a factor 9. AAV is a pretty small virus. So unfortunately, we're not yet able to use this type of technology to put in something like a von Willebrand factor gene, because that's just a really big gene. They've had to do some really careful microbiology to even be able to fit in a factor 8 construct. But essentially what they are able to do is package the genetic information to teach the body how to make factor 8 or factor 9 within this AAV viral vector. And then that goes into a solution that you see here, essentially a clear fluid in an IV bag, similar to if you've ever had to get IV fluids. And then it goes in as an intravenous injection. Infusion really over sort of 30 minutes to an hour. It depends a little bit on the gene therapy itself. And because of some of the characteristics of the AAVs that are used, they hone to the liver in particular. So these like to go to hepatocytes or liver cells. Once the vectors get there, the coding, the viral vector starts to break down, and the genetic material makes its way into the center of the cell. This genetic material, by and large, takes up residence near our own cell's DNA, but doesn't primarily integrate into the DNA. There is some low-level integration that can occur, but unlike some of the other types of gene therapies, cell therapies in particular, the main mechanism of how this works is not by integrating into the cell's DNA. But just having that genetic material in the cell, it's able to leverage the machinery of the cell to take that DNA information, to make RNA, to make proteins, and in this case, the factor 8 or factor 9 clotting protein. And then the protein is secreted from the liver cell into the circulation and makes coagulation factor that's ready to participate in making a blood clot if we need to. There have been such an expanse of gene therapy trials, AAV gene therapy trials in hemophilia A and B, that I can no longer even keep them on one slide. So this just gives you a snapshot of the current hemophilia A, so factor 8 gene therapy trials. You can see a whole host of different products that are being investigated. Some of the details of the actual AAV vector that's being used is one of the things that varies a little bit across the gene therapy programs. They all essentially use a pretty similar approach to factor 8, but each one has its own sort of nuanced and proprietary modifications to try to improve how quickly and how effectively factor 8 is produced once it gets into the liver cell. And you can also see that they run the gamut of where they are in clinical trial development. So some are just in preclinical trial, moving into phase 1. Some are in those early phase 1, phase 2. But as you can see, we also now have a number of later stage phase 3 trials that are ongoing. And this is another area where, if you're really interested in hemophilia A or B gene therapy trials, you can see these are all listed so far on clinicaltrials.gov. So that's another great resource to, again, go to learn more about gene therapy. It's slightly more modest on the hemophilia B side, but you can appreciate here there's still an impressive number, I would say, of gene therapy platforms of all phases of development looking at this therapeutic option in hemophilia B as well. So that's a little bit of where they are in development and how they are different from factor replacements. So let's talk a little bit about who's eligible for gene therapy. And so broadly speaking, there is some variability across the different gene therapy platforms. Most of them are only recruiting, I think all of them actually are only recruiting male patients. They are all recruiting those who are adults over 18. The baseline factor activity, whether it's 8 or 9, varies a little bit from less than 1% to less than 2%, somewhere in there. And the vast majority of them require patients to be previously treated patients with greater than 150 exposure days, though there's a couple in there that require just 50 exposure days. I think it's pretty difficult for the most part in the US to find men over 18 with severe disease that haven't had at least 150 exposure days. There is a bit of variability with some of the other inclusion criteria. Some programs do include or exclude anyone who has HIV. Others exclude only those with uncontrolled HIV. Universally active hepatitis B or C, or ongoing treatment for hepatitis is an exclusion. But remote history of hepatitis C, if you've gone through curative therapy and don't have significant fibrosis or liver disease, some of the platforms do recruit those individuals as well. And also because AAV is pretty common in our environment, while it doesn't cause disease in humans, that doesn't mean our immune system doesn't react to seeing that in our body. So in some cases, individuals have seen AAV that's similar enough to the viral vectors where there's already neutralizing antibodies or an immune response that's anticipated. So most of the programs look for these neutralizing antibodies and have some type of exclusion criteria if they're present. And they're pretty prevalent. So while it varies a little bit, the specifics between AAV to AAV, around 40% of the population has some type of antibody response. There is one gene therapy trial, and I will highlight them briefly, that uses a little bit of a different AAV and has not been excluding individuals with neutralizing antibody. And for their particular platform, that seems to be working out okay. So what have we learned about the effectiveness? So I think when we think about the various gene therapy platforms, not unlike some of the factor concentrate platforms or other substitution rebalancing therapy platforms, there is a number of ways that we're thinking about assessing effectiveness. So certainly looking at the frequency of bleeding, the annualized bleed rate or ABR is a common way of assessing effectiveness. Looking at the factor activity levels that are produced, especially the peak of those, how well they sustain over time, how much fluctuation there is in them is another way that's being used to assess efficacy. The duration of expression, so how long are we seeing the liver cells making and producing the factor 8 or factor 9? And while I don't have a readout on these latter but really important points, looking at changes in pain, discomfort, emotional functioning, quality of life assessments are also a big component of evaluation for effectiveness of the gene therapy trials, and have been incorporated into the other types of clinical trials for other modalities of therapy as well. So let's start with looking at some effectiveness. And as I mentioned, and as you probably gathered from all of the different clinical trials that were presented on other slides, I couldn't possibly do justice to each of the fantastic gene therapy platforms and programs and data out there. So I have sort of handpicked a few representative and some of the more recent data and more mature data. So this is Valrox or Roctavan. What you see here is on the y-axis, we're looking at factor 8 activity levels. On the x-axis, we're looking at time post-infusion. And so the scale here is on order of weeks. So you can kind of appreciate 4 weeks, 8 weeks, all the way to 200 and I can't even read now, 295 weeks. For this particular data presentation, they looked at a couple of doses of gene therapy. So the green is a higher dose of the gene therapy. The tan is a lower dose of the gene therapy. And what you can see with these stars is essentially the average of the factor VIII levels for the group of patients. There were 7 patients in the green group and 6 patients in the gold group. And then the box is the 25th percentile to the 75th percentile. So what I think you can appreciate from these data from their early study is that for the higher dose group, perhaps we'll focus on this one, is that pretty quickly, within a few months of receiving gene therapy, on average, folks went quite high, well into the normal range with their factor VIII levels. But you can see that when you look from the 25th to the 75th percentile, it's a pretty broad range. So even at the 25th percentile, folks were well up into the mild range, 25, 30, 45%. Some actually overshot. If you look at the most extremes here with the error bars, over 150%. But you can sort of see a vast improvement in factor VIII levels. You can also appreciate 52 weeks is here, that while those factor VIII levels were maintained over the course of the first year, as we continued on, those factor VIII levels sort of gently declined a bit. So you can appreciate, again, it continues to be a wide range, and folks well still in the mild range, some still in the normal range, but a bit of a downtrend. But fortunately, it seems, though we're all continuing to watch carefully, the rate, how quickly the downtrend is occurring, seems to be hopefully leveling off. So one of the questions, of course, that we posed early on is sustainability, durability of the expression of the gene therapy programs. And so this is something that's being watched really carefully. They also, for this same gene therapy product, have been recruiting into their pivotal trial, or their late stage, their phase 3 trial, and have more recently started to be able to present some data even beyond 1 year for participants in the late stage trial. And so here is data for 17 participants. So the prior one, you'll recognize, one group had 7 patients, one group had 6 patients. So this fortunately represents a larger group of patients. And what you can appreciate is the setup is the same in terms of factor VIII activity levels on the y-axis, and post-vector infusion on the x-axis in weeks, that the average still kind of goes up in the same way. With the design of the phase 3 and dosing, levels didn't get up quite as high. The ranges do seem to be broad, but perhaps a bit more narrow. And the overall sort of rate of kind of up and down seems a bit more consistent here. So when we look at the average use of factor VIII product for those individuals who participated, perhaps not surprisingly, down 99%. So since folks did so well getting their factor VIII levels out of the severe range, they required much, much less factor. Bleed rates declined significantly, about 84%, from an annualized average ABR of almost 5 to about 1. And after 5 weeks post gene therapy, about 80% of these participants were bleed free. The total of the gene therapy trial recruited 134 patients. So still, of course, more data coming out of this program, more data to come, which I think will hopefully shrink some of the error bars and give us additional confidence in fluctuations, both short-term and longer-term in the gene therapy. Also, as mentioned, looking at effectiveness, looking at bleeding symptoms. And so, as one would expect, when your levels go from very low to higher, you can see that bleeding in the 2 different dosing groups before infusion was quite high, with ABRs, annual bleed rates, around 16, and in the years post-infusion decreased pretty significantly, and this was true of both dosing groups. If we take a peek at one of the factor IX gene therapies, we see somewhat similar and exciting, I would say, results. These data are presented a bit differently. Again, we have the factor IX activity on the y-axis and weeks post-infusion on the x-axis, but rather than having the means and 25th percentiles, kind of this summation of the different patients put together, each of these lines in different colors represents its own participant. So from here, you can see similarly the rate of increase of factor IX expression increased over the couple of months post-infusion. But again, there's a pretty wide variation. So this one individual shot well up into the normal range. Many individuals seem to fall more in the 10 to 40% range. And over the just over 2 years for many patients represented here, it does seem to be relatively consistent levels. But again, when you're looking from patient to patient, certainly looks a bit more noisy. I would say similarly, looking at effectiveness for bleeding, and in this case also factor use, we see similar results. So if you look at the bleeds observed in this population across the different dosing cohorts in the 1 year before gene therapy, some with numerous spontaneous bleeds, some more with traumatic bleeds, but post the gene therapy and the increase in their factor levels, 94% reduction in bleed rate, and correspondingly lots of infusions, either on-demand treatment or prophylactic treatment beforehand. And as the factor levels rose post gene therapy, marked reduction in the need for infusions. Another of the gene therapy products that I said I would mention is factor IX, is the AMT-061. This is data from their phase 1/2 trial. So this is just 3 patients, and similar to the last study, looks at the factor IX levels on the x-axis, weeks post-infusion on the y-axis, and each of these lines represents its own participant. And you can see, though we have just 3 participants here for this gene therapy trial, a bit less broad results. So each of these 3 were sort of in the 30 to 50% factor IX range. So they went up over the course of the first few months post-injection, and then at least up until the first year seemed to have relatively sustained expression. This study now is in phase 3 and has 54 patients that they have reported on in that phase 3 study with a mean factor IX expression of about 37%, 26 weeks post the gene therapy trials. This is the gene therapy platform where they are looking and measuring for neutralizing antibodies, but did not exclude folks from being dosed as a result of those neutralizing antibodies. And for this particular construct, that didn't seem to make a difference in terms of the factor IX levels that they saw. And they're now seeing sustained factor IX levels for up to 18 months. So again, looking across the different gene therapy programs, not only for short-term success, but increasingly long-term durability. And the very first gene therapy trial that was published in 2011 was a hemophilia B gene therapy trial. And they are now actually getting closer to 10 years out. The levels, because of the platform and the factor IX construct that they had at the time, are much lower level than I just presented with the newer gene therapy trials. But here we have the benefit of looking at some of the durability data, at least in the hemophilia B space. And so you can see at 6 and 8, and as they've begun to present more data, now 10 years out, we have seen sustainability. And as they followed these patients for many years, while there was, and we'll talk about this in the safety, some increase in liver enzymes and some challenges around the immune response to gene therapy shortly after infusion, as they got beyond that first year, there have been no additional issues with the immune system or kind of reactivity against the prior gene therapy product, no factor IX inhibitors, no late toxicities for these patients, and sustained levels. So there's a lot to think about with these new therapies and thinking about AAV-mediated gene therapy. So we're monitoring carefully and thinking about short-term adverse events, including how are things going in the liver. So I mentioned that the target of these gene therapies are hepatocytes, our liver cells, looking for inhibitor development, not just to the AAV constructs, the vectors themselves, but to the coagulation proteins, which fortunately we have not seen so far, the immune response to gene therapy, and the potential for clotting risk, especially for some of those patients that sort of overshot perhaps the normal range, especially for factor IX. Also, a lot of attention to long-term adverse events. So thinking about the development of other disorders. I mentioned that there can be low-level integration of AAV into the host genome, making sure that it's not integrating in a deleterious way or a way that might predispose to development of cancers or other long-term problems. And then since the immune system does react ultimately to create these neutralizing antibodies, some of the vector neutralizing responses, and what does that mean for our ability to retreat or treat again in 5 years, 10 years, 15 years, and then obviously keeping an eye on mortality or different causes of death for individuals. 2 cell therapies that I will mention briefly. So a lot of the gene therapies focus on hemophilia A and B in adults without inhibitors. There is actually a cell-based gene therapy that's being investigated for hemophilia A patients with inhibitors. So unlike the in vivo approach to gene therapy, where you just inject the gene therapy product and it makes its way to the host cells and does its thing, when we think about cell-based gene transfer, what that entails is taking cells from a person, and oftentimes, and in this case, they can be blood cells. So we can stimulate the bone marrow, for example, and then we actually get blood stem cells circulating temporarily in the peripheral blood. We can draw those cells off, and then we can collect and identify those cells in particular. And then those cells in the Petri dishes that you see here can be modified. And in this case, they're modifying those cells to add factor VIII into the cells that ultimately make platelets, so that platelets will have factor VIII, extra factor VIII stored in them. Once they modify those cells, then they put those cells back into the body. Those cells have to go back and will hone back to the bone marrow and hopefully then start creating the precursors to platelets that have been trained to make factor VIII. If all of that works, we'll have platelets that have more factor VIII. Platelets normally circulate around in the blood and are really first responders to blood vessel injury. And so this will help direct factor VIII right to the site of injury where coagulation is happening. Platelets normally secrete a number of chemical mediators that are important for upregulating the coagulation cascade. And so we'll get extra factor VIII coming out at the same time. And the idea is if the platelets are protecting essentially or keeping inside the factor VIII, then the factor VIII isn't going to be subjected to inhibitors as quickly and as easily as when we infuse it intravenously. It'll be right there, and hopefully we'll be able to take action with the other activated coagulation factors before the inhibitors can sweep it away. And hopefully, as we have a number of platelets that have the factor VIII, it'll sort of overwhelm potentially the inhibitors. So this is at least the hypothesis, and something that is recruiting in phase 1 studies for this population. So I don't yet have any specific safety or efficacy data to share with you in that regard. A different approach to cell therapy, which is not a gene therapy, is SIG001. And you could think about this as an encapsulated cell therapy. So in this particular case, this company has designed these special spheres, and they're highlighted blue here so that they are visible. But within these spheres are a bunch of cells that have been modified to generate and essentially overproduce factor VIII. The spheres are also specially designed so that they keep those cells together within the sphere and hopefully protect the cells and themselves from causing any immune reactions in the body, causing fibrosis, so that they can generate factor VIII. The factor VIII can sort of seep out from those spheres, make its way into circulation, and increase factor levels that way. This is sort of an interesting approach because, as I talk about spheres and cells making a protein and secreting a protein, one could appreciate that while 6001 is looking at making factor VIII protein, you could imagine that you could use that type of a platform to make and secrete a number of proteins. So a number of coagulation proteins, and also a number of other proteins that can cause non-bleeding disorder, non-hematologic diseases. So this is exciting not only for bleeding disorders, but I think has great potential application for other diseases as well. Well, how do these little spheres work? Where do they go? So it turns out that these spheres are actually placed in the body, and these are placed in the body using a laparoscopic procedure. So I use cartoons. Hopefully this isn't too much for folks. So when we do laparoscopic procedures, this is where there's just tiny incisions made on the abdomen. Usually this, oops, let me go here. Tiny incisions made on the abdomen. Usually this one, which is the camera, actually just goes right through the belly button. And then using these little instruments and the camera, one on the video camera can see what they're doing on the inside. And then these spheres are just placed within the fatty tissues that live in the tummy. The fancy name for that tissue is the omentum. So the idea is that the spheres are placed within the abdominal cavity. There's lots of nutrients, there's lots of space, things kind of are a bit free flowing in the abdomen. But the idea is if you have enough of these cells, or enough of these spheres with cells inside making factor VIII, the construct of the cells won't irritate or cause fibrosis or problem within the tummy tissues. And the cells will kind of thrive in that environment. The spheres will thrive in that environment, continue to make factor VIII or the other protein. It gets secreted, picked up in circulation, and then circulates around. And so this is I hope, again, this is not too much for folks, but this is sort of a picture of what some of the fatty fibrous tissue looks like, omentum in the tummy. And what you can't even barely see is kind of here are these teeny tiny little clear spheres. So that's actually what the 6001 would kind of look like in the body. So the benefits of this type of approach is that there is no integration of these cells with like the body's own cells or bone marrow. There's no intention of bringing genetic material within the body's own cells. They live in the abdomen. The challenge, of course, is it's hard to know how long these spheres and cells will be viable, will continue to live and produce factor VIII. And then as you can tell from this picture, once they're in there, they're in there. There isn't really kind of going back in and removing those spheres, as it were. But potentially the opportunity to redose or just add back more spheres to give the body back cells that's making factor VIII. So this, similar to the other study, is very early in phase 1, so I don't have specific in-person safety or efficacy data to share. The last thing I'll just talk about is the rebalancing therapies. So the rebalancing therapy concept is that, we have proteins that are responsible for helping us make blood clots normally. We call these procoagulant proteins. And then to keep the balance, we have proteins that are anticoagulant proteins, and that they should kind of balance each other out. So when we have missing procoagulant proteins, we bleed too much. And if we were to just take off some of the anticoagulant proteins, perhaps we could sort of even the seesaw back out a bit. I think that's a really helpful way to think about these therapies. I would just caution and remind folks that the coagulation cascade is actually a lot more complicated than just kind of like an even balance. And there's a lot of crosstalk and activation amongst the various clotting factors. So as we make some of these modifications, we just have to do so thoughtfully, judiciously, and with careful monitoring. Turns out there's actually a number of products that are being investigated in this space. Some of them are referred to as anti-TFPI or TFP, tissue factor pathway inhibitors. Others are focused on other anticoagulant proteins, such as knocking down antithrombin or knocking down activated protein C. You can see a variety of them actually are now making their way towards phase 3 trials. Some of the other protein C and some of the other anticoagulant proteins are a little bit earlier on in their phase trials. And most are looking at adolescents, young adults, so those that are greater than 12. Again, focusing on hemophilia A and B. And in terms of the effectiveness, and this is not at all any kind of direct comparison, it was mostly just shortening of slides. Fitusiran, as you'll remember from the prior slide, knocks down antithrombin. When they looked at individuals using fitusiran for prophylaxis and their bleeding rate before the study, it was higher than that after the study. So maybe an effective form of prophylaxis. And similarly, this is one example of one of the TFPIs. When you look at the annualized bleed rate for those without inhibitors, less for those on the prophylaxis compared to before they were on prophylaxis. So some sense that these are effective. These do all generally are subcutaneous therapies that might be administered daily, once a week, once a month. So do provide some different administration in that regard. I would say overall, these therapies have been pretty well tolerated, subcutaneous, so there have been some injection site reactions. But the big safety issue across these platforms has really been thrombotic risk and clotting. There has not been many clotting events. We're talking about, in some cases, 1 or 2 patients per program. But enough with this new therapy that it has caused some halting of the various clinical trial programs, as you can see here, with some thoughtful redesign about how we're dosing the medications, how we're thinking about treating bleeds, and it has caused the discontinuation of some of the programs in this rebalancing therapy area. So I think for some of the bleeding indications coming to mind, in particular hemophilia B with inhibitors and some of the bleeding disorders that are just much more difficult to treat, where we really don't have a lot of other good treatment options. I think the risk benefit certainly weighs in favor of at least considering these types of therapies. But for other individuals with different types of bleeding disorders with other alternative treatments who are doing well, the risk benefit may or may not be the right fit for this group of therapies. So with that, just a few quick closing remarks, and then we seem to have a few questions. So it's really exciting, I think, to see this expanding portfolio of hemophilia therapies. And I do believe it's really going to allow us to individualize the approach to care, whether it's subcutaneous, intravenous, gene therapy, based on what that individual needs, how they're doing with their bleeding disorder, what that means for them in their daily lives, and how we can best manage them. I think more than ever, there's really a need for engagement with patients, with families, to understand the options, whether it's for licensed available therapies or participating in clinical trials, and really verbalizing those goals, goals of treatment, goals of life, because they're going to be different for everyone, and they're going to be different at different stages of life. And I think having thoughtful patient-provider decision-making is just critical. I think the gene therapy and cellular therapies continue to be promising for improving factor 8, factor 9. I think that there are good opportunities even for von Willebrand factor 7, some of the more rare bleeding disorders in this regard, but they'll be tested a bit later once we have a bit more data on the more common bleeding disorders, as it were. And in these spaces, close look at short-term and long-term expression, reliability of what levels we're getting, the durability, safety is going to be really important. And I do think that the rebalancing therapies, and I didn't get into other substitutive therapies, but there are other substitutive therapies similar to current licensed products that are being studied, will come to clinical trials. I think continuing to look at them as prophylactic options, especially for different populations that don't have as many options and have a lot of burden of disease, is going to be important. But the coagulation cascade is really complex. So I think considering carefully risk of thrombosis, how using some of these therapies increases the complexity of what I call hemostatic management. That's just a fancy way, I suppose, of saying bleed control. When there's other comorbidities, other diseases, major bleeding, major trauma, critical illness, that's where some of the complexities of the coagulation cascade kind of really peak. And I think good experience with these therapies is going to be critical to success and careful management of preventing bleeding and also preventing clotting in those individuals. So with that, I will say thank you, and I'm happy to take any questions.
Fantastic, Dr. Croteau. Thank you so much for an incredible
high-level presentation that really talked about kind of where we are. I was wondering, before I get into the questions, could you put back on that slide the bucket areas? Because that may be good in the very beginning.
Yeah, absolutely.
Great. And as you do that, if you have additional questions, I know we're past 8, but feel free to add the questions into the chat, and Dr. Croteau will answer them as they come along. So as she's getting that slide up and running, there was a bunch of questions that came in about, perfect. Yeah. I like that one because it clearly demonstrates kind of where we are and where we're going. Biv, am I saying them right? Biv 001 concentrate. So the questions were, is this longer lasting factor? And how long does it last for compared to some of the ones that are on the market today? Someone said that there's a product right now that could last up to 72 hours. Is this different than the long acting current treatments?
Yeah, that's a great question. So the data coming out for this particular factor VIII concentrate looks like at a week, at 7 days, folks are still having levels of about 5%. So it looks like this therapy, even at standard dosing of just 25 units per kilogram, could easily get individuals to once a week dosing for factor VIII. And then certainly they're exploring actually higher dosing as well. So 50 units, 65 units per kilogram. So more than what a typical prophylactic dosing is with our current therapies. But if you ratchet up dosing in that regard, you're actually looking at week levels in the teens. So I think really compared to what I would say is a very modest difference between, say, standard factor concentrates and what we know as EHL or extended half-life concentrates, where you've heard, 1.3, 1.5 times extension. The modifications to this product really do seem more substantial, so that we could get to once a week dosing with still very good trough levels in the high single digits. Great. And potentially higher.
Fantastic. Shifting gears a little bit to, and I apologize, I'm going to butcher some of these names here. The Marza PTACOZ Alpha Marza AA.
Yep, perfect.
All right, hopefully you can understand my coding here. If not, I'll go into Morse code. What is the difference between existing factor and this one? And then the second part of that is, who might use this for prophy, patients with inhibitors or others?
Excellent question. So again, I would say the difference here is the duration of this factor VII molecule seems to be a bit longer than the currently licensed products. And I think perhaps even more importantly, or more excitingly, the ability to administer that subcutaneously. So we currently don't have options or data to support subcutaneous administration of the currently available factor VII products. And so if you were a hemophilia with inhibitor patient, this could potentially serve as a prophylaxis option, potentially, similar to licensed products when we did bypassing agent prophylaxis. In the hemophilia A with inhibitors, of course, there is alternate prophylaxis now with emicizumab, the bispecific antibody. But for hem B with inhibitors, for example, this could be potentially something to be looked at. And I think also excitingly, potentially, is the use of this for bleed treatment. So presently, licensed products like emicizumab work for prophylaxis, but are not used to treat bleeding. So if you're on prophylaxis with emicizumab, hopefully you've heard from your provider that you still need to have unexpired factor VIII doses at the ready, or unexpired recombinant 7A doses at the ready in case of a bleed. Increasingly, though, for many patients on emicizumab, they may have lost some of their peripheral infusion skills, or they may not have ever had peripheral infusion skills. So now they're sort of in a position where if they have a bleed, they don't have the right skills to be able to treat independently. And so that causes some frustration, of course, needing home infusion nursing, having to go to the infusion center, having to go to the emergency room to help get help with treatment. Having a subcutaneously administered bleed option, I think, would be potentially beneficial for a lot of folks with inhibitors. So that would be another potential difference and opportunity there.
Great, thank you. Shifting gears a little bit to other rare, ultra rare, or other types of bleeding disorders. A question came in is there any perspective for preventative treatment for conditions like qualitative platelet dysfunction or some of the other not so talked about bleeding disorders like that?
Yeah, so some of the platelet function disorders are tricky. So I did highlight one in particular being Glanzmann's thrombocytopenia, which for a variety of reasons, in many cases, is already treated with recombinant 7A. And so I think there's a kind of exciting that in this talk, compared to some of my others, I was really pleased to actually be able to include a few subtypes of von Willebrand disease, Glanzmann thrombocytopenia, factor VII deficiency. So I do think there's some exciting things there. There is a lot of work to help with synthesized platelets and other opportunities in that regard that may help with bleed treatments and things like this. So I wasn't able to highlight all of them there today, but certainly platelets are an active area of research, both because of low platelets or thrombocytopenia, not enough platelets causing issues for some individuals with bleeding, as well as platelet functionality problems. So I do think that we'll be seeing more in that space as well.
Great. A couple of more questions about treatment, and then they'll switch gears into gene therapy. Have you heard of any research surrounding how frequently patients that have overcome an inhibitor need to be exposed to actual factor substitutes to keep the inhibitor at bay if they choose to try an alternative approach?
Yeah, so that we just don't really have data on. Fortunately, there are a few different studies that are starting to recruit patients who, say, have recently tolerized and are interested in switching over to emicizumab to try to learn more about that. So I think it's good if you're in that category and you're willing to participate either prospectively, kind of moving forward, or even, you know, in the future, kind of as we might look at groups, look back retrospectively to see how folks do. I think it's going to be helpful. Some of the challenges, the absolute number of patients is pretty small, so I do think it's going to take a few years, in absolute truth, to really get our head around some of that data, to just collect enough patients in that situation where we can really have a good sense of what that number is going to be.
Great. Switching gears to gene therapy. We recently saw Bluebird, which for those that are not familiar is a gene therapy company, I don't think for hemophilia, but for others, halt their gene therapy for a cancer risk. Does this affect bleeding disorder gene therapy trials at all?
That's a really great question. So the gene therapies that affects is a different type of gene therapy. So the gene therapy, for example, for sickle cell disease and some of those other diseases are cell-based gene therapies. So those are all the gene therapies where they actually take out cells, they change the genetics of the cells, and then they put the cells back in. So it's a kind of a whole different platform. And when you have the cell-based therapies where you're taking cells and putting them back in, it turns out that you also have to give some extra medicines to the body to kind of allow for those cells to go back in and have a place where they can sort of grow and expand. And it turns out that some of those medicines are pretty harsh with respect to the immune system, to the bone marrow. And so for the cell-based gene therapies, there has unfortunately been sort of a series of careful investigations that have to go into the mechanisms for how and where they're actually inserting the gene into the DNA within the cells that they're using for the cell therapy, and then also the impacts of the medications that they're using as part of what they call the conditioning, or part of getting the cells back into the body. So there's a few different things that are very different from the hemophilia approach to the AAV gene therapy that could potentially predispose to that kind of cancer risk.
Great, thank you. Do males that undergo gene therapy need to forgo having children for a period of time?
So we're learning more about different places that the viral kind of vector goes and is shed. So it is requested, and this might vary a little bit from platform to platform, that individuals use barrier protection and forego having children for I think many is at least 6 months or to a year, just to kind of minimize any risk. The AAV is not known to get into reproductive cells. It does get into some of the reproductive tissues, secretions in that sense, but is not known to kind of alter the genetics of those tissues. But since there's a lot of unknowns, to be safe, it's requested to use barrier protection and wait about a year.
Great, thank you. In regards to any gene therapy, do you expect that having factor to treat breakthrough bleeds will always be necessary?
So based on the kind of the data that's emerging, I would say it's variable. So there are proportions of patients that are actually hanging out in the normal range. And while I do think it's going to continue to be important to check in, especially early on as we're kind of learning the trajectory, I would say at a minimum once a year and probably every 6 months or so, especially further out from gene therapy, to ensure we know where individuals' levels are. If you're in the normal range, and you get to go to surgery without extra factor, and you get to not have factor at home. For those that are more in the mild range, I would say it depends a little bit more like how you're doing and what your access is to medical care and medical facilities with factor. If you actually keep it at home, or if with injury, it would be something that you would need medical attention for anyway. So I think it'll be pretty variable depending on what your factor level is and what your overall situation is.
Another question with gene therapy. Clotting factors are made in the liver. Understanding that most are made in the hepatic cells, while factor VIII is made in the endothelial. Thank you. Cells. Can the vector be targeted to those cells specifically? Does it matter where the vector is targeted?
That's a great question. So factor VIII is made actually in the sinusoidal endothelial cells in the liver anyway. So the cells sort of right adjacent to the hepatocytes. And part of the reason that they target the hepatocytes is the hepatocytes, the liver cells, really are specialized at making and secreting proteins. So the liver makes a ton of various proteins that we need, albumin, the clotting factors, et cetera. So they're really geared for that. And with respect to some of the careful design of the vectors themselves, the promoters and how to sort of manage some of the machinery within the liver cells is a little bit more well understood and accessible. So I think it makes sense to target the hepatocytes. Plus those AAV viruses tend to, by their nature, the ones that are selected and modified target the hepatocytes better. And so I don't know that we've yet seen any issues with it being produced in the hepatocyte versus the neighboring sinusoidal endothelial cell. But I don't anticipate that they'll sort of change direction and try to target a different cell in that regard.
I think we need one session just to go over the way you pronounce some of this stuff here. Maybe we can make a song or something like that.
There you go. I love it. Audio dictionary.
Yeah, exactly. Some of the terms that you mentioned in your presentation, what does it mean for exposure day was on one of the slides?
Yeah, so that just means that a day that you've had clotting factor in your body. So an exposure is sort of when you're kind of exposed to something, like if you go out and you're kind of exposed to sunlight. In the same way, when we infuse factor, that would be an exposure day. I would say that's the most common definition. There may be some out there that say, oh, an exposure day counts, if the clotting factor hangs around for, more than 24 hours. But usually we think about it as number of days that you've had a factor VIII infusion.
Great.
Or factor IX or what have you.
Is there a resource you recommend for following up on the terms and information presented tonight? There's a lot. And I like to learn more. Absolutely.
We have a few really great review articles that I'm happy to share with you that have some glossaries of terms that can be helpful. I think checking out some of the clinicaltrials.gov sites, there are some nice background sections in there that can help go through some of the terms and some of the information and connect. And I think increasingly NHF, ISTH, some of the national and international groups are putting together some educational materials and workshops and things like that, so that there are more kind of glossaries, quick videos that highlight some of the things that I just described in words that could be helpful to you.
Great, and I'll put a plug too. I know Dr. Croteau, you helped us with this the first year, but in our consumer med program, the box, there's now 9 pages of definitions that's good in the program of terms that you're going to hear that the committee has helped oversee, and that a medical provider has looked upon. So please register to get that box, because there's a lot of information to help you, because it is a lot. You know, when you're hearing some of these terms, you know, it could be overwhelming, whether you have hemophilia, VWD, platelet, other rares, but this all applies to everyone. And you're certainly not meant to be an expert in it, but definitely be aware of it. So when you hear talks like this, it can help you go along there. Another question that came in is, with cell therapies evolving and the implantable pouches, is it occasional replenishment of cells needed, and how often and how invasive is that?
Yeah, that's a great question. And the answer is we just don't know yet. So the encapsulated cell therapy, the 6001 that I mentioned that fits that description, is just moving into phase 1 trials, so first in human trials. And so this is where we'll learn more about, is that approach even enough to raise factor levels in the blood, and by how much? And how long does it persist? So with these early phase trials, this is where we learn about how well do participants tolerate it? Are we seeing any factor levels? What do we think is the duration? So hopefully in the coming months to year, we'll start to have some data that is presented from that group on how things are going, and we'll be able to answer that better.
Great. Switching gears to VWD, we had our VWD retreat not too long ago in November. Dr. Connell from your center presented on the new guidelines that are very exciting for VWD. You mentioned a couple of products, but is there anything else in the pipeline? And could gene therapy that's being studied for hemophilia eventually be used for some other bleeding disorders like VWD?
Absolutely. So I would say that kind of in the pipeline, sort of akin to BIV001, which I mentioned is now starting some early phase trials in the types of VWD that result in low factor VIII levels. There's also some interest in starting clinical trials, and whether this will be through the manufacturer or potentially investigator-initiated trials, and looking at some of those substitution therapies like emicizumab for those populations also. So emicizumab, of course, mimics activated factor VIII. And to the degree that some of the bleeding for individuals with type 3 von Willebrand disease or type 2N von Willebrand disease is due to the very low factor VIII levels, could something like a bispecific antibody like the emicizumab or others that are coming down the pipeline in that category of medications, could that be something that helps those specific types of von Willebrand disease patients? So another potential option and investigation to do there. And absolutely, I think that there's opportunities for both gene therapy and potentially this encapsulated cell therapy to help the other coagulation disorders, including von Willebrand disease, factor VII, some of the other more severe but rare clotting factor deficiencies that, similar to hemophilia A and B, require prophylaxis. I think the gene therapies and some of the therapies that are being developed that are intended more as prophylaxis as opposed to bleed treatment, those may not lend themselves as well to some of the coagulation deficiencies. 11 comes to mind, for example, where many individuals with 11 deficiency only have bleeding challenges at times of surgery, for example, or with significant injury, and don't really usually leverage like a prophylactic therapy, generally speaking. So I think that will be a little bit of a different category. But for those with the severe 7, 10 deficiencies that in many cases also need prophylaxis, I think there's going to be some good opportunities there also in the future.
Great. Fantastic. Last question that came in is SIG001 sounds quite interesting. Does it provide a constant release of clotting factor? And if so, how is the release controlled? And if you could just remind everyone what SIG001 is.
Yeah, so 6001 is that encapsulated cell therapy where you have the spheres that would be placed in the abdomen using a laparoscopic procedure. And then those spheres contain cells that are producing and secreting factor VIII. And the answer is this is something that we're going to learn more about. So there is no like on-off mechanism for managing those spheres. So ideally, and you know, generally the way cells work is, you know, they're taking in nutrients, they're living, and they're generating various proteins that are being secreted. So one would hypothesize that they would, as they're kind of living and doing their thing, make and secrete these proteins at a relatively consistent rate and release them at a consistent rate. But how efficiently, effectively they do that, and whether they're really good at doing that at first and levels go up, and then, you know, decrease by 50% in a month or 6 months or 9 months, and then another 50%, or whether it's kind of a gradual decline over time, or whether they stay nice and consistent for a very long time, is something that we're going to have to learn from those early phase and then later phase trials.
Great. Fantastic. Those are the questions that came in, Dr. Croteau. Thank you so much for this incredible presentation. A lot to cover. I think, you know, as said in the chat, we could have gone on for hours here, which for those that are on, it's just the beginning. There are so many opportunities to dive a little bit deeper with next week's webinar, the live session, the exhibit hall, and then following up with Dr. Valentino. So Dr. Croteau, thank you so much for spending your Wednesday evening with us. We really appreciate it.
Excellent. Thank you guys for having me. Good luck with the rest of the medical symposium.
Fantastic. Thank you. Before we head out, I'm just going to go over what is next. So we had the emergency therapies talk tonight with Dr. Croteau. Next week, same time, 7 p.m., St. Patty's Day. Bring your corned beef and potatoes and wear your green, because we're going to drink some beer as well. We have a great panel. We have Dr. Madrid from Dartmouth, Dr. Sally Pels from Rhode Island, Emily Bisson from Connecticut Children's, and Sheila O'Donnell. They're going to be covering 4 topics. Understanding all the current treatments. So you go to your HTC, comp clinic, or your provider. How do you process it all? Establishing a good working relationship with your provider, telehealth, and emergency situations. And this is for all bleeding disorders. So it's a panel discussion, you know, going back and forth. The next one is Saturday, March 20th. 9 to about 11:30. We have an insurance and a psychosocial, and then you get to go into breakout rooms. So some of what Dr. Croteau presented tonight, some of these trials, you can speak with the medical and science liaison of these companies and ask them even more questions during these breakout rooms. Following that, based on feedback, is COVID and bleeding disorders. Dr. Len Valentino from NHF is going to cover all your questions: vaccines, herd immunity, COVID, blood clots, VWD, all these questions that already came in. He's a wealth of knowledge, and it's going to be a great conversation. Starting on March 20th to March 31st is when we have our scavenger hunt. For those that have done it in Goose Chase with trivia questions, you can win gift cards, and then the exhibit hall goes. And because I got a private message about this, you can see what the fanny pack looks like. Everyone wants to wear this. It's really cool. It's waterproof. Again, we are going to give you the tools during this event to put in your fanny so that you can then be a stronger advocate. Bonus points to whoever wears them to their comp clinics and has their logs in them, or I would say medical ID, but we want them on your wrist, not in your fanny pack. Then with that said, this is just a snapshot of what last year's exhibit hall looks like. The exhibit hall will officially launch on the 20th. And then I just want to say thank you. Thank you for being part of our Consumer Medical Symposium. Of course, this doesn't take place of being in person, but we are so thankful that we can provide this, that there's technology that no matter where you live, and many of you from are across New England, across the country, that can participate in this event tonight. So we hope to see you next week. Please register for the events. And again, Dr. Croteau, thank you so much for spending your time with us. Have a good night, everyone.
Thanks so much. Have a great night.
Thanks, Rich.